Thank you all for participating in the session on anemias. Before we get started, I want to let you know that we have launched the post-activity survey questions on the polling tab next to the live stream feed. Please answer these two questions by scrolling down the tab and clicking submit after each submission. We will review and discuss the results of the pre and post-activity survey before the end of the session. And thank you for those who have already submitted questions on the Q&A tab. Please continue to do so if you have additional questions. And I want to welcome our panelists, Dr. Alexis Thompson and Dr. Sujit Sheth. Unfortunately, Dr. Ware could not join us, who will be discussing the talks in this session and answering your questions with me. So the first question is, when utilizing Hydrea in hemoglobin SS disease, is there a target hemoglobin F fraction above which painful crises and other morbidities are decidedly reduced? And conversely, achieving below what hemoglobin F level would indicate a hydroxyurea failure in an individual patient? Alexis, would you be willing to take a shot at that?
I'll sort of give it a shot, Jim. Thank you. So this is a really interesting question, and it's actually a bit complicated. I think we'll need to take it apart because I think we want to make the distinction between clinical benefit and clinical response and laboratory response to hydroxyurea and sickle cell disease. So in general, the target hemoglobin fraction that has been associated with most clinical outcomes that are positive has been 30%. Having said that, we can definitely see improvements in a number of parameters above 20%. The individuals who are likely to have the greatest prediction for clinical response based on hemoglobin F are those whose baseline hemoglobin Fs are higher. In terms of looking at hemoglobin F alone as being the predictor of hydroxyurea failure, there isn't really a threshold because often that failure really is clinical. And there definitely are individuals who have a laboratory response, yet don't appear to have a clinical response. And the converse is true. There are individuals who are clinically better, yet their fetal hemoglobins do not rise. And so while I think it's been an important parameter for looking at hydroxyurea and hydroxyurea monitoring, I think it needs to be considered along with many other things in terms of looking at the overall benefit of hydroxyurea in sickle cell disease.
Sujit, do you want to add something?
I agree completely with Alexis. I think we've all seen patients who've had a response from 2% to 6% or 8% who are responding very well, maybe not 100%. And it's very hard to really tell what effect it's having on the natural history of the disease itself. But given that we have long-term data now, we've been using hydroxyurea in an approved manner for 22 years and in studies for at least 10 years before that. We know that it increases your life expectancy. So it is absolutely having some benefit or having some impact on the natural history of the disease. So irrespective of what the fetal hemoglobin level alone may be, I think if somebody's having a clinical response, it's absolutely worthwhile to continue them on it.
I think the other parts of that too, Judith, and I'd be curious what your thoughts are. Often I will see certainly the MCV rise. And yes. So there are times when even I just have a CBC sitting in front of me. If there are questions at all about compliance, most patients who are having a response to hydroxyurea should have an elevation in their MCV.
Yeah.
Slightly.
Yeah, the other thing also we see is, most patients who are not treated with hydroxyurea have high platelet counts and high white counts. And those tend to come down as well with hydroxyurea since it does have, somewhat of a myelosuppressive effect. So I think that is another sort of surrogate marker for compliance as well, even if you don't see the increase in fetal hemoglobin. And that actually might have an impact on vaso-occlusion as well. I'm sure the white cells and the platelets participate in some way in the vaso-occlusive and vasculopathy that happens as well. So that might be a benefit too.
Yep. Agreed.
Can you both go a little further into the idea? I thought Dr. Ware said in his talk that you would start hydroxyurea at a certain dose and titrate up. What do you look for when you do that?
So the recommended starting dose for hydroxyurea is 20 milligrams per kilogram per day. It's usually given as a once daily dose. It comes in primarily in pill form, but it can be compounded into a liquid now in many major medical centers. And what I'm typically looking for, we've already talked about. I always get a metabolic panel as well as a CBC and an electrophoresis to begin with. I'm looking to make sure from a safety perspective that I'm not seeing increases in abnormalities related to their liver functions or their renal function as we at the start and then as we move up. As in terms of when to escalate, I expect that the fetal hemoglobin will rise. The MCV rises first. The hemoglobin F should begin rising. I like being able to see a suppression of their total white count. I agree with Dr. Steth. I think that there definitely is a component of the benefit of hydroxyurea that's associated with its myelosuppression. And so if I'm seeing someone whose fetal hemoglobin is modestly rising, but whose total white count is still staying the same and they're having no other side effects, then we incrementally go up, probably about 5 milligrams per kilogram at a time. For children, we pretty much max out at 35 milligrams per kilogram per day. Some people argue that adults, maybe it's only 30. Quite frankly, if I'm not seeing clinical benefit and I have no concerns about compliance at 35 milligrams per kilogram per day for at least a few months, I'm reasonably satisfied that this may be someone for whom hydroxyurea is simply not beneficial. But I do want to make sure that I've given someone an adequate opportunity to respond. Having said that, there definitely are some people who are starting on the first dose and are not dose escalating at all. I think that there is reasonably good evidence that dose escalation matters and that there are probably more benefits than just simply giving people fixed dose only. And so I think that that should be part of the protocol when you begin people on hydroxyurea is an intent to escalate to benefit.
I agree. I think the intent is to get to the maximum tolerated dose and see how much of an incremental benefit that has. And by tolerated, it's just, you don't become neutropenic, you don't have an effect on renal function or hepatic function, and you just keep going up to that max of 35. And I think we've used 35 for adults as well. Sometimes erring on the slightly lower side based on the capsule size and, what it rounds off to for that individual in terms of number of 500 milligram pills to take. So it's, we can use that also as a way of titrating the dose up.
And is there anything that either of you would use to titrate the dose down?
Certainly toxicity is the most common thing. So neutropenia, actually even anemia in a few patients will get me to dial back. Or people who just have intolerable GI symptoms. Although for some of them, we try to begin with at least, say, dividing the dose and seeing if they get some relief of the GI symptoms with that. It's always the caveat, though, when you start increasing the number of doses that are required, you have to appreciate the risk of noncompliance. With someone only now getting one dose daily that's only 50% of your total dose, you haven't helped yourself that much. So I think we kind of have to be aware that as we make these adjustments that we're still trying to encourage adherence by patients.
And there's a question about toxicity with hydroxyurea, and I just put it up now. It's strategies for overcoming toxicity, and they're talking primarily about ulcers and skin rash. Do either of you have any thoughts about that?
So the only thing that I would say is the skin rash, in my experience, has been transient, that it has not persisted. And so as long as we can support patients, we get through that because the rash ultimately goes away. The skin ulcer question is an interesting one because ulcers, of course, are a manifestation of sickle cell disease, unfortunately, and hydrea has been associated with ulcers, and so for some patients, it's really trying to understand what do I think is the best association. If this is someone who, for instance, has had a history of skin ulcers and they end up getting breakdown in the same location as they previously had a skin ulcer, it's hard for me to attribute that solely to hydroxyurea. On occasion, I've stopped hydroxyurea to allow a skin ulcer to heal, but I can't really say with any certainty that the hydroxyurea caused the ulcer. I think that in some ways, we're very fortunate in 2020 to now have 4 agents to think about that are disease modifying. And so perhaps I would have said something different in 2016, but I think today, knowing that I have other disease modifying therapies to consider, I'll make some adjustments as best I can if I think someone otherwise is having a good clinical response to hydroxyurea. But I'm also willing to give up on hydroxyurea and move on to another disease-modifying therapy as long as the patient's willing to try something else.
So just on that point, Alexis, let me ask you, would you still consider hydroxyurea for a naive patient, who's not received anything? Just given, the reason I ask is, one, given the long history that we have with the drug, and 2, given the cost, which is significantly lower than any of the others.
Right. So I can't say that cost necessarily factors into it as heavily, although I can imagine for some people their payer might. But I think one can make a really strong clinical argument for starting with hydroxyurea for exactly what you mentioned. We have 20 plus years of experience with hydroxyurea, and hydroxyurea is the only one that we have enough information to say that it actually improves longevity. Right. That mortality goes down with hydroxyurea. And, can I say that 20 years from now for crizolizumab or Indari? I don't know. But I could easily make that case. I'm also far more confident of giving hydroxyurea to children. And the amount of data for Indari or Foxylator or crizolizumab is limited in children. And so, say for the clinical trial setting, it's not clear to me that small children should be offered Voxelotor or crizolizumab because they are not FDA approved below the age of 12 for Oxbryta and 16 for Adagveo. I would argue there is a small amount of data for Indari or L-glutamine down to age 5 or 6, but I can't argue with the volume of very impressive data for people across the entire lifespan with hydroxyurea. And so that alone, to me, is the reason why we should think about offering people hydroxyurea first.
I agree. I'm just happy that this discussion is going so much, is focusing so much on hydroxyurea now rather than, even I don't think it's too late to talk about hydroxyurea if we can increase its utilization.
I think you're absolutely right, and the price point I think would make many payers happy. I would say that I'm persuaded by the number of patients who have complaints and very sincere complaints about hydroxyurea and side effects. And so, I think in the past I would have said, look, can you just tough it out for another month or two? And I still do that with a fair number of people, especially early on. But I don't see a paradigm in the near term where we're going to abandon hydroxyurea. No.
Okay.
Perhaps in a minute we might come back to some of that, but what I wanted to ask is, Sujit, I know you've published on stem cell transplant for sickle cell disease with, I think, Dr. Bhatia.
Yes.
And I wonder if you would comment on it. The question is, I'm sorry, I should have put it up. The question is, when do you consider transplant for sickle cell disease?
So I think Alexis is a transplanter, and I'm going to let her go first because I think that this is something that has changed a little bit over the years, and I might add some comments at the end. But as a transplant, I think Alexis, you should take that one.
I'm happy to give it a shot. So I would say that that for sickle cell disease, the first person transplanted for sickle cell disease was now over 30 years ago. It's hard to believe. Yep. And I think that sickle cell patients who have relatively severe courses, who are fortunate enough to have an HLA matched sibling, should be considered for a transplant. So they should at least be referred for a consultation and have a discussion with the transplant team. And severe sickle cell disease initially was defined primarily by side effects like overt strokes. But I think recurrent severe pain, recurrent acute chest syndrome, and even in some cases an abnormal TCD, in which case in a patient who otherwise is on chronic transfusions indefinitely, are all indications that I think are well accepted for stem cell transplants. Again, sibling transplants, HLA matched transplants from siblings should be the standard of care. I think some of the more recent data with sibling transplants in adults now, using the protocol that was developed by the group at the NIH, the results I think are incredible. The early results for adults, even with sibling donors with sickle cell, was uniformly fatal. And I think that many of us walked away from transplants in that population because of that. But I think the more recent data suggests that with proper support and with a less intense conditioning regimen, a regimen that focuses more on immunosuppression and less on myeloablation, is probably adequate for adults. Haploidentical transplants and matched unrelated donor transplants, there is increasing amounts of data to suggest that those are options. I would say that for both of those, our best results are still in children. And so I'm not convinced yet that haploidentical or matched unrelated donor transplants for adults with sickle cell has arrived yet. I think that increasingly, people want to move the ball forward in terms of looking at curative therapies. And so certainly the notion of, instead of bone marrow, looking at hematopoietic stem cells with the patient being their own donor. And so using a gene therapy approach with an autologous transplant is also particularly appealing. Certainly not approved anywhere in the world as a treatment, but some incredibly exciting clinical trial results for using an autologous transplant for sickle cell disease. My strongest recommendation, though, is that consider it early. I don't think that it should be the last resort anymore. I don't think that it's okay for us to have people really have almost intolerable side effects or really to have suffered over an extended period of time without considering all of their options. And today, I don't think that it's unreasonable to have patients be seen by a transplant specialist for at least a consultation fairly early.
And I just want to add to that. Philosophically, I completely agree with Alexis on all of her points. Philosophically, however, I will say that I don't think that symptomatology is necessarily required in order to consider a transplant if you have a matched sibling donor. I think that we all know that this disease is very unpredictable. There is yes, we can do TCDs, and yes, we can predict who's going to have a stroke if your TCD is elevated, but there are plenty of patients who have strokes with normal TCDs. And there are plenty of patients who develop pulmonary hypertension with no warning that this is going to happen. And that absolutely shortens your life expectancy. And, the median life expectancy as of 2010 in Dr. Hassel's paper was 39 and a half years. That is half the life expectancy of the average American, or about that. So I feel very strongly that if you have a matched sibling who can be a donor, it should be considered very seriously, irrespective of whether you've had symptomatology or not. And if the parents say no, and obviously earlier is better, as Alexis said, if the parents say no, I'm not willing to take that kind of a risk, that's fine, but it should at least be discussed.
I think the other part of that too is that when these children are put into comprehensive care, by and large, many of our babies with sickle cell have parents who, in all likelihood, are young enough where they would consider having another child, ideally another child, though without sickle cell. And so we have increasing number of families who are utilizing technology to do pre-implantation genetic diagnosis and in vitro fertilization to ensure that they not only have future children that don't have sickle cell, but potentially a baby who can be an HLA matched donor for their child with sickle cell. Similarly, we strongly recommend for all families, even if their kids are doing wonderfully, we strongly recommend that families who have additional children that they arrange to have the cord blood harvested and saved for the future. Most of our families take us up on that one. And so even if they don't go to transplant in the near term, that clearly you only have that really limited window of opportunity in the delivery room for that future healthy sibling to actually take advantage of that and have that cord blood stored.
Okay. Sujit, would you comment on transplant for thalassemia? Are there some differences in how you approach the two diseases in deciding?
I think, and this is a really interesting point because, for thalassemia, if you have a matched related donor, most patients actually go to transplant. This is the perception in patients' minds. Again, I'm talking about transfusion dependent for the most part. Yeah. Is that you're transfusion dependent. This is going to be a very cumbersome disease that is going to interfere with your quality of life, and you can have complications down the road and stuff like that. Given that, we've made such advances in terms of, the safety of the blood supply, the availability of oral chelators, more than one oral chelator, the way that we monitor the patients, the way that we are able to provide comprehensive care, I think that especially for children born after the year 2000 in the era of oral chelation, I'm anticipating even near normal life expectancies with a very cumbersome and very, very involved disease, but otherwise you should be able to do fine if you're compliant. Yet, if you have a matched sibling donor, you go to transplant. In my experience, 90% of patients that I've had who've had a matched sibling donor, parents have elected to go forward with transplant. 90%. So I think that for a disease that is very cumbersome but can have good outcomes, where you're saying go to transplant, and then on the flip side of it, you have a disease that, like sickle cell disease, where you can't predict and you have a lower life expectancy, and so you're saying don't go to transplant or don't necessarily go to transplant. I think that this to me it bothers me that I can't say to a sickle cell patient, look, even though your child has no symptoms, I don't know what's going to happen when your child is 18 or 20 or 25. And since there is the opportunity right now with good preserved organ function at the age of 4, consider it. So I think that, and even in the thalassemia world, even for non-transfusion dependent patients, if they're showing a more severe phenotype where they might need to start regular transfusions, and if transplant is an option, they go forward with transplant. So I think this is something that is quite different, and I think philosophically people approach it differently, which to me it kind of bothers me. I don't know what Alexis thinks about that.
Well, a fair number, but certainly not all of my thalassemia patients have gone to transplant. But I think you're right. I mean, one would think that there should be some consistency in our approach across hemoglobinopathies. And so I think your point's well taken. I have been impressed at the outcomes for thalassemia. I think at this point, if the procedure is being taken up at a point in time where patients have very limited iron overload and no organ dysfunction, they should do well. And I don't think that there's anything that anyone can, I don't think that that's disputable at this point. And so a sibling transplant really should be the standard of care. I am persuaded, however, by the number of families with both sickle cell and thalassemia who do have some trepidations about the risk of fertility with our current approaches to transplantation. And I definitely have had both thalassemia patients and sickle cell patients express some hesitation about proceeding, knowing that their child is perhaps too young to participate in a meaningful conversation about what their thoughts or wishes are about their future children. And so I have had a couple of families with thalassemia whose children are well controlled, who are doing well with transfusions, do not have excessive iron overload, but have consciously decided that they wanted to wait until they thought that their child was old enough to at least participate in the part of the conversation about fertility preservation.
Just to clarify, I'm saying have the discussion. I'm not saying go to transplant for all. I'm saying if there's an option, at least have the discussion. Offer it as an option.
You're both saying that, I think, right?
Yeah. Yep.
I would go to another question, if that's okay, and this is also about sickle. The question is about combining crizanlizumab and voxelotor, but it seems to me, and please, you two know so much more about this than I do, that hydroxyurea is easily the number one best therapy, not only the cheapest. So I would imagine if you were doing combination therapy, it would be hydroxyurea and something else.
Yeah.
Go ahead.
So,
Perfect.
Jim, this question comes up all too often. But to just be completely clear, there is no data, zero data on using crizanlizumab and voxelotor combined. And so today, there really is no recommendation that's evidence-based for using those two together. Having said that, there have been clinical trials that have been completed with the combination of hydroxyurea and crizanlizumab, and also the combination of voxelotor and hydroxyurea. And in each one of those cases, there seems to be benefit. There does not seem to be increased side effects with hydroxyurea added to crizanlizumab or hydroxyurea added to voxelotor. Unfortunately, the data is pretty limited right now, and we're not seeing an additive effect. I think that had been the hope, that you would see an additive effect. I think since hydroxyurea has now become the standard of care, there really was not good justification for asking someone to stop using the standard of care to participate in a clinical trial. And so you were allowed to continue on hydroxyurea if you were already on it. But I do think that we need to stay away from any recommendation about combining these two new agents. It's very tempting, in part because, A, because they're new, and B, because their mechanisms of action are different, one being an inhibitor of adhesion and the other one anti-sickling. And so if one can think about sickle cell disease now being multifactorial, that there are multiple effects of that single genetic mutation, it's tempting. But I think we have to resist that because really we do not know about side effects, and we certainly know nothing about benefit. And so it is a clinical trial in the offing, in my opinion. But today, this really should not be pursued outside of a clinical trial.
I agree completely. The problem is I don't think the clinical trial is going to happen because two different companies make the two different drugs. And it's really going to be investigator-initiated. It's going to have to be investigator-initiated. I doubt that they're going to come together and say, let's do a trial and see if the combination works.
Yeah, I think I've got to agree with you on that one.
Right. So it's going to be investigator-initiated, and that costs so much money that getting funding for it is going to be a challenge.
Yeah.
I suspect in the meanwhile that people will use it off-label. And I just hope that if they are, that they're collecting data rigorously and paying attention to all of the different. I'm not recommending it by any stretch, but if they do, then collect the data and be very rigorous to look for side effects and possible interactions and stuff like that as well.
Agreed.
Yeah, when So one more question that maybe we could have shortish answers to, and that's if there's any role of erythropoietin, I guess possibly with other treatments like hydroxyurea.
So, but with both sickle cell and thalassemia, when we're talking about those conditions alone, in both of those cases, erythropoietin, endogenous erythropoietin is high. And so there's only going to be a marginal benefit of adding exogenous erythropoietin to the mix. I think the primary exception, unfortunately, are those patients with sickle cell who develop end-stage renal disease. And there is a subset of young adults with sickle cell that they do develop end-stage renal disease as a complication of sickle cell. And in those instances, there is some benefit for erythropoietin. But I would say that save for that, there also was a small amount of data quite some time ago about combining hydroxyurea with EPO for thalassemia intermedia. I think that data really was marginal. I don't think that there's a lot of interest in that combination. It had been used in the past, especially with dealing with extramedullary hematopoiesis. But fundamentally, even though these are anemias associated with if anything, high EPO levels. And so the role of Aranesp, in my opinion, is pretty limited.
And driving ineffective erythropoiesis is kind of pointless. You already have a significant amount of ineffective erythropoiesis. Driving it even further. They, as Alexis said, they have high EPO levels already in the thalassemia population. In the sickle cell population, when you already have a hemoglobin of 6.5 and a tick count of 20%, how much more can you drive this process without worrying about developing bone pain and precipitating a crisis, making you hypertensive, making you at risk for thromboembolism? I mean, the side effect profile is not really great for patients with sickle cell disease who already have underlying risk factors. So I think I think that it's if it's to be used, it's very select indications, as Alexis mentioned, somebody with chronic renal disease maybe, but otherwise, it's I don't think it's really that worthwhile to push further a process that's already not working very well.
Yeah, I've also had personal experience with a question about using erythropoietin in the setting of an aplastic episode in someone who, for religious objections or whatever, will not allow transfusions. Sadly, I've not found it to be terribly beneficial in those settings, but I have used it for lack of any other way to support those patients. That's probably the only time, and I can't really say that I saw much benefit, but it was just certainly if there was even some marginal benefit for a patient who is otherwise unstable with their dropping hemoglobin and no possibility of transfusing them, we've tried it.
Listen, thank you both very, very much for giving the talks and participating in such a great Q&A. We're now going to take a break. During this break, you can visit the exhibit hall, and please come back at 3:20 or in about another 2 to 3 minutes when we start the session 4 on thrombophilia. Thank you.